Welcome to the Birth Lounge Podcast, an empowering space for expecting and new parents to hear candid conversations with experts, support your mental health, and learn the tips and tricks that thousands of parents have used to craft their ideal birth. We will answer all of your questions, the scary ones and the weird ones, to help calm your fears and feel confident going into your birth. I'm going to help you redefine what birth and motherhood looks like and how to embrace your journey. I've intentionally crafted a list of experts to help you navigate pregnancy, explore your birth options, and plan for postpartum so that it can be a time of soaking in your tiny human. We're going to go there on all the hard topics so that you can dive deep into finding your confidence and freeing yourself from fears around birth. With over 10 years of experience in family education and a master's degree in human development and family studies, I created this podcast as a way to share the resources parents need to make educated and informed decisions about their care in pregnancy and childbirth. This is a birth community driven by evidence-based information and research in hopes to help you explore your options, understand your rights, and know what choices you have along the way when it comes to birth and beyond. I'm your host, HeHe, and let's get to the good stuff. Sarah, welcome to the show.
Thank you, HeHe. I'm so excited to be on talking to you.
I'm so excited to have you. I'm making my
Aw.
rounds with our little Nashville group.
I
I'm having
know.
everybody on the show because, and I say this every time I talk about this trip, but genuinely, you guys are so just like good, gold-hearted people, and it's very hard to find that in the online space, and just I think sometimes with women in general. And so it was just so refreshing and so fun to meet all of you guys. And instantly, I obviously knew I wanted to have you on the podcast and share you with my audience and the other people that I love so much. So thanks for being here.
Of course, it's such an honor. You're just such a sweet person. We all love you.
Oh my goodness. Thank you
Yeah.
so much.
Aw.
It was very much, and you get what you get. So yeah, okay. So today I think is going to be a really good episode for a lot of people, but I think it's going to be funny because I don't think a lot of people think about postpartum in the hospital. I think we do a lot in general, probably because the conversation always is, oh, I plan for so much for the baby, but I never thought about after the baby. But I think that's true actually in the hospital too. We think a lot about, okay, how am I going to get to the hospital? When do I go to the hospital? What's it going to be like in labor and delivery? What can I say no to? What am I going to say yes to? What are they going to offer me? What decisions am I going to be faced with? But we never think about, okay, my baby's here. I don't get to leave the hospital. I'm going to a different unit, and there's still things that have to happen there. When people do realize, oh, yeah, I'm going to go to postpartum, I think a lot of times they think they're just like, go into a hospital room and people are going to be checking in on them every now and then that's kind of it. You get discharged. But there's a lot more that goes on in postpartum. We're monitoring a lot of things. There's a lot of people that are keeping tabs on you. We're also monitoring your baby. It's a lot in postpartum. I think people are unprepared for that. So I would love for today we could talk about the things that people can expect from the postpartum experience, from their nurse, what providers are coming to talk to you and see you, what are we looking for in your baby, and how do we get from transitioning to postpartum all the way to discharge and what that process looks like. Yeah.
That sounds perfect.
Cool. Okay, so I think the first thing we should start with is let's have you walk us over from labor and delivery. So you're all cleaned up, you have had all your repairs, you and your baby are looking good, you guys, and your labor and delivery nurse leans over and goes, I've had the best time with you guys, but it's time to give you to postpartum. So I'm going to actually help you gather your things. Dad, can you grab the backpack and all that stuff in the corner? And we're actually going to walk over to postpartum. So we meet you in postpartum, take it from there. What can we expect?
Yeah. So it is pretty standard practice to do bedside shift reports. So the labor and delivery nurse will talk to me, the postpartum nurse, or whoever has you. And we just go over everything about your birth. So they tell me like any meds that you got. So they tell me like your history, your feeding goals, your goals for just pretty much everything for the rest of your stay. So they just give me a quick down and dirty on you. And then we're supposed to look both over you so that when we're handing off on report, she can say, hey, this is like what her belly looked like for me, yada, yada, so that we're on the same page. And so when I'm doing my assessment later, I just know what you've already been like, what the status quo has been. Yeah, we do a bedside shift report. We both look over you. Then usually your labor and delivery nurse leaves. Now, I will say too, this is a good point to make, is some units are LDRP, which is labor, delivery, recovery, and postpartum. So you might just have the same labor nurse for the rest of their shift. And then when shift changes over, you'll get someone new. Like things can change, but a lot of like usually smaller hospitals are like that, where you might just stay in your same room. You might still have the same nurse like the whole time you're there.
That's kind of
um
nice. It's not that
yeah,
yeah.
yeah, a lot of people do like that, but it just really depends like on the hospital. So my hospital's pretty big, so we just wouldn't be able, with like how many patients we have, we wouldn't be able to keep one person in their same room the whole time. Like our labor and delivery unit, I think, has 14 beds.
Hmm.
And then our postpartum has, we have overflow areas and stuff too, but 27.
Wow.
So we just have a lot of like people coming and going. So we can't just keep any one person in their same room. So it's more, if that's important to you, you can always ask your provider or your hospital, call ahead of time and ask them what their unit is like, if that is very important to you. What is it like for most of the hospitals in your area?
Yeah, same thing. We're very used to handing people over to postpartum. They're two different units, but
Oh,
remember, listeners, I'm in Boston, so I have MGH, Mass General, and Brigham, and Beth Israel. So we have those larger teaching hospitals. So yeah, for sure. When you get out in Connecticut, even they are LDRP in some of those hospitals. So we see the same thing, but a lot of them here, you do have that transition.
yeah, I think that's just good to know because people will ask me that in videos I've made. They're like, "Wait, I thought you stayed with me
Oh.
the whole time," and I'm like, "It just depends." So,
Yeah, I never thought about that either to educate people on. That's a very good point.
okay, but so after we do our initial assessment, I just go ahead and talk to the patient about what the next however long time is going to look like. So I try to not bombard people, but I'm like, okay, let's just talk about the first 4 hours. So
Okay.
the first 4 hours after delivery, we're going to come in your room at least every hour, and we're going to just do a fundal check. And of course, you and I are very much on the same page as this, but you can always refuse whatever you want. So I'm like, we are technically supposed to come in here every hour and do a fundal check. It's not always a full rub. If you are like in a lot of pain, if you've been given a ton of stuff like a bunch of pitocin or methogen and stuff, and you're already rock hard, I'm not going to put you through more pain, but I'll at least check where it is and just feel that everything feels okay. So we come in your room, do that every hour for a vaginal delivery. We just do the fundal rubs every hour for 4 hours. And then if it's a C-section, then we also get your vital signs every hour too. So we do a fundal rub and we do a set of vitals for the first 4 hours. And usually during that time, like we're just checking your pad, we're just making sure you feel comfortable. I'm like promoting bonding skin to skin with the baby, just educating my patient on where everything is in the room, like procedures. There is some paperwork I have to have them fill out. It's typically an infant safety and security stuff. So I go over, hey, just make sure that your nurse is like someone with a pink badge, that they work here, that we're always checking their bands with yours. If baby like ever leaves your side for whatever reason, when we bring them back, we just need to verify your bands with babies. We just go over housekeeping stuff like that. And then I have them sign those forms that they just know about the safety stuff for the hospital stay. We also have to have them sign a infant sleep form that's also just, hey, I don't really care what you do when you go home, but when you're here in the hospital, you cannot sleep in the bed with your baby because it is just not safe with the way it is, the hospital beds. So please don't do that. People have to sign a consent form for that. No blankets in the bed, big fluffy blankets or anything with your baby, stuffed animals, stuff like that. So that's like the first 4 hours. It's just I'm trying not to overwhelm people, but I'm also making sure they know what's going on. I make sure to ask them like, do you need to eat something, especially if they've had a C-section? I'm like making sure they got their snacks, they got drinks. I'm asking them, what are your goals? What do you really want to accomplish in your stay right now? And we write it up on the whiteboard. So a lot of people say breastfeeding is probably, if they choose to breastfeed, then breastfeeding is usually a really important one. They're like, I just really want to work on that. And then the other one is people want to take a shower. I'm like, I'll write them up on the board. I'm like, yep, we're going to try and knock those out, get the stuff done that you want to get done because I'm here to help you. And yeah, that's the first 4 hours. Usually, at least, so every hospital is going to have a very different protocol on this. But at the end of the 4 hours for me is when if they want to get up sooner than that, they can totally get up and go to the bathroom anytime. But if there's a C-section at the end of the 4 hours, we at least get up. I try to get them up as long as feeling's back in their legs. If they feel like they can do it sooner, totally. But a lot of people around 4 hours, I feel like, is when they're like, I feel like good enough, I can get up. So we'll get up, we'll walk to the bathroom, and they have a Foley catheter still at this point, but we'll just change their pad, rinse them off. I'll change their bed, just make them feel fresh and clean. And then at my hospital, the Foley catheter can come out. And I usually tell people, let's wait to take a shower until it comes out, just because then you'll just feel like you can really get everywhere really good.
Sure.
So
Okay, talk to us about why we get up after birth, right? Especially after a C-section. We want people getting up to prevent blood clots, but what's the point in making us be active in those hours afterwards or around that 4 hour mark?
there's just so much research that shows the sooner you move and you get up, it's just so much more beneficial for like pain management, for a big thing that I'm sure your clients complain about too is gas pain is a huge one
Mm-hmm. Mm-hmm.
after C-section, and that really catches people off guard, especially if you get it like up in your shoulders, your back. And so moving can really help get that moving, get that out. You can take a gas X and stuff too, but it's just so helpful with like your GI motility, like just the sooner you can move. I don't want to ever push people, but I'm like, if you can at least get up and do a few little walks, like every couple hours, at least get up and go to the bathroom, do a little walking. I feel like that makes such a huge difference for like people's pain. Even if they're like, I didn't feel like doing it in the moment, but then I'm glad I did it, is what everyone says.
For sure. I always equate it to like after a really hard workout, if you go home and you just sit on the couch, it is going to be killer to get up and try and walk once you are sore, right, from that workout.
So
But
true.
you know that once you get up and go and your muscles get warmed up, you're going, the soreness doesn't go completely away, but it's way better than when you first get going. So just
Yeah.
think about that. Okay, so I do have a question about the fundal massage. Let's say you have a patient that refuses the fundal massage or the fundal checks. And we talked about it, you guys, in our episode with Mama Nurse Tina about the differences between fundal checks and fundal massages. So these are fundal checks. If someone has declined them and they have decided it's not right for them, what are some other signs that we are looking for that they can self monitor that they would want to alert you as their nurse of, hey, maybe we do want to check things down there and we might want to have a conversation about these fundal checks?
Yeah. That's such a great point to make. I do go over this with my patients, but I'm like, if you feel like trickling, it just feels like that blood is like coming out and it's continuous. Like
Okay.
it's normal if you're like, I move and then I feel a gush, or like I start breastfeeding and then I feel a gush, but then it like stops. If it is
Okay.
just like continuous, like I just feel like it's constant, never hesitate to call your nurse and be like, can you just look down there, just check it. If you feel a large, literally like a jellyfish, like clot, any clot, if you feel like a bloop, I don't even know how to describe it, but a lot of patients tell me it feels like a little jellyfish coming out of
Yeah.
their vagina. But if you feel a lump, we would just want to check the clot. If it's a clot, how big it is, what it looks like, its consistency, it's all that. So just if that happens, I'm trying to think what else. Mainly it's like the trickling, a gushing. Is
If
there
you're
anything else?
lightheaded, if you're feeling like
Uh,
really lightheaded, you should definitely let your nurse know. Kara, how big is too big when it comes to clots?
we say if it's bigger than a golf ball.
Okay,
Is
so a pretty decent sized clot. That I think that
uh,
would freak a lot of people out just to see
yeah.
that size of a clot come out.
I know. And I always tell people, because people will be like, oh, I didn't want to call you or bother you. I'm like, please call me.
Call
Like
me.
I don't care if it's the size of a teeny tiny whatever. If it worries you, I would want you to have peace of mind. So please don't ever worry about bothering anyone. Like it is our job to help you. And like we want to help you. I want you to feel like you can ask us anything. So don't be like, oh, well, she said it has to be a golf ball. Like, no, just call anytime. So
Yeah, definitely. You
that's fine.
you are always better off calling and having the reassurance that it is nothing than to
Mhm.
not call and it actually be something. And also that's what your doctors and nurses are there for. Just Give them a call. It's really nothing for them, you guys. I promise. They will not even think twice about it. Okay, next question is pain relief. We briefly mentioned this, but can you talk us through our pain relief options? I think a lot of people get really nervous about the pain after tearing, the pain after their epidural comes out, or the pain after C-section. So, what in general can we expect for pain relief after a vaginal delivery and then after a C-section?
Yeah, that's such a great question. Okay, so again, this is going to vary on probably hospital and the doctor, but I feel like what I just hear most from like other nurses and just what we do is like pretty much on the around the clock we will offer you Tylenol and Motrin. So
Okay.
like for us we do it every 8 hours. And I feel like for most people if you have a second degree tear, like a first degree or no tear, like that usually does really well. I feel like I and most people's pain is very well managed with a extra strength Tylenol and an extra strength ibuprofen that we do every 8 hours. But if that is not cutting it, like we always can go move up in our options. We usually have like we call it like PRN medication, so as needed. So we usually have something that's like our next step up if you're braiding your pain. So we have to ask you like your pain scale and if it's above a certain threshold, then we can offer you something stronger. So my hospital, we have oxycodone and we have oxycodone 5 milligrams, we have oxycodone 10 milligrams. If you're allergic to that, then we can always talk to your doctor. We can do something else. Like we have so many different other things we can, and your doctor will know your allergies beforehand. So typically it's not even something we would have to call them about. Hey, she said she's allergic to this. They already know because you've been their patient. So they will have already, should have already put an order in for something for you that's specific to you if you've already had a conversation with them. Now we also love to do non-pharmacologic stuff too. We can do ice packs on your vagina if you tore. We can do, if you're having really bad cramps, we can make a hot pack for your belly to help with cramps. I'm trying to think. Like even in a when we chart it in the computer, we have all these options like for things that we like offered or we can try to do. I've never had anyone ask for this, but like literally even like massage or like I want a massage to relax. Like we could
Could
if
you
you
please
want.
massage me? I just pushed a
Yeah.
baby out.
Yeah. Hey, I'll do it. But yeah, distraction is one of them. Like, which sounds so silly. Like, just watch some TV or something. No, I feel like that's so silly. But just distract yourself. But literally, like, we have so many things up our sleeve, though, of other things, like non-farm stuff that we can try to help too. We have physical therapists and occupational therapists
Nice.
that come to see all our patients. So they'll come also work with you. Now, as far as I know, you said C-sections, it's actually really similar. We also do ibuprofen and Tylenol around the clock. And then we also do gabapentin, which helps with like nerve pain. So we do all three of those. Like we'll do all three every 8 hours. If we need something for breakthrough pain, then we have the oxycodone. I would just say that's like the most typical. That's probably like 95% of my patients. Those are all the things that they do. But we also have other things like sometimes we'll give Toradol or we'll give, I don't know, just lower tab or I don't know. There's just other random things we can do. So we have other things if we need it. If something's not working for you, then don't be afraid to tell your nurse and we can always talk to the doctor, the provider, whoever, midwife, and ask them like if we need to change something for you.
Definitely. That's exactly where I wanted to take this is just to remind people like you don't have to be in pain. So if something is painful for you, just let your provider know. Like somebody will get you some help and it may take a couple times of like kind of in
Mhm.
what pain meds will work for you. Or even figuring out what's causing you the pain. But definitely don't
Right.
just sit in pain. We don't want that for you. And if you're in pain, your body's not going to make milk. It's not going to be able to heal. You're not going to be able to relax. We want you to be a nice, relaxed mama so that you can will heal and make milk. Okay, so let's transition to who is coming in our room
Mhm.
after we have our baby. Maybe we cover the first 24 hours because it's not just for mom, it's for baby too. We've got some
Mhm.
providers coming in to check baby too.
Yeah, no, exactly. That's great. I even have that and I have a book that I wrote and I have a little blurb on that. I'm like, here are all the people. Because I'm like, just so you know, it's all in this list. But anyways, but yes, so let me try to think. Okay, so obviously you got your nurse, you have lab because lab is gonna come draw your labs. It just depends on the hospital. But a lot of times they get a post hematocrit right after delivery on mom. So you'll get that drawn. They just want to make sure that you didn't lose too much blood in delivery. And of course, you can always refuse if you don't want to do something. Just letting you know, this is like typically what they do. You have lab, and then there are labs that get drawn on your baby too, but those usually aren't until 24 hours, right at the 24-hour mark. You have a hearing screen that gets done on your baby. That some places the nurse does that. In my hospital, we have specific hearing screeners. So that's going to be potentially a different person who comes in your room. Your doctor or midwife, whoever your provider is supposed to see you like at least once a day while you're in the hospital, other than your delivery, obviously. They're supposed to see you each day. So let's say you had a C-section, that's post-op day, that's 0. So then post-op day 1, so your first day after delivery, you will have your provider or someone in their group will come and see you. And then they have to come see you the next day. So post-op day 2, post-op day 3, or whenever, like until you get discharged, someone has to come lay eyes on you and see you. Usually someone, if you did have an epidural or if you had a C-section, someone from anesthesia will come around on you and just make sure that like you're doing okay, no residual weirds, anything going on that they need to check on you for. Let's see, the pediatrician comes to see the baby. This depends on like the time you delivered at. If you delivered like early in the morning, or then your pediatrician might be coming later that day and see you. If you delivered, let's say it was like 5 p.m. you delivered, they probably won't see you till the next day. They don't have to see the baby. I think it just needs to be within 24 hours. So they can come see you like the next day if you delivered at 5 p.m. the day before. Who else? You have cleaning people come into your room. You have the food and nutrition people come and dropping your meals off. You probably will have nursing management coming by your room around and asking if everything with your nursing staff has been okay. If you have anyone you want to, they'll come and ask, is there anyone you want to recommend? Any nurse that you just really loved and had a great experience with? Give a shout out to. Is there anyone you had a problem with? Is there anything we can do better for you? Shoot, I'm trying to think. But with all that said, I do want to say this. You can always put a do not disturb sign on your door.
Oh, that's a good idea.
Yeah, we have them at my hospital already printed out, laminated with a magnet. So if I need to take like a 2-hour nap, whatever, we'll put that on the door. And it says, please check at the nurse's desk. Do not come in the room. So like they'll come, let's say it's a food person. So the food delivery person comes up to the desk and they're like, hey, I saw the sign on the door. I'll be like, hey, can you just leave the food at the desk? I'll take it to him later. And like most people, like 9 times out of 10, unless it's a doctor, usually they ignore the sign, they go in anyway. But some of them are really sweet, and are really great about it. But most of them are like, I'm going to go ahead. I'm going to go ahead.
Oh, right on brand. We love that.
I do love them. There's some great
I love
ones
them
I work
too.
with.
I say it in the nicest, most sincerest. You just don't even. I get it. I get it.
Yeah, I know. Sometimes there's other people who ignore it, but most of the time people come and they check with us first. So I just always tell people that. I'm like, I know it seems so many people. It is a lot
Yeah.
of people and it can be very overwhelming. Oh yeah, the birth certificate lady too. That's another one.
Oh yeah. Add that in there.
Yeah. There's probably 3 more that I'm forgetting, to be honest. I'm not even joking. Like WIC, if you need WIC, then they
Nope.
come and see you. So it's a lot of people. A social worker potentially, physical
Okay.
therapy, occupational therapy. Look, there's 3 more people I just named. So seriously, we try to cluster things together. But seriously, if you need a break, just tell me and we will make it happen. So
Yeah, I like that. Okay, talk to me about that do not disturb sign. Is there anything that would knock somebody out of not being able to have maybe a couple of hours? Anything like a really severe hemorrhage or something like an emergency hysterectomy needed to happen in birth? Is there anything you can think of that you might say, that may not be the best option for you because we need to keep a little closer eye on some
yeah,
things?
yeah. For those things you mentioned, for sure, there might be a patient and usually the patient has been through something like that. They're like usually I know, I'd rather you guys check on me and I understand that.
Totally.
But we could still keep it on the door and maybe your nurse still needs to come in there, but none of those other
Okay.
people do. So
Yeah.
we might still have it on the door because if it has been something like a hemorrhage, we don't need like the birth certificate lady coming to talk to you right now. This is not the time. So we'll put that on the door. But we'll still come and pop in and just make sure you're okay.
Okay. I like that. I know it feels really busy. It's often a complaint that we get from clients once they return home and we go visit. They're like, it
Yeah,
was just a lot of people. And I'm like, I
I
know,
know.
but
I feel
they
so bad.
I know, and I feel bad too. It's things that have to happen though, right? It's eyes
Yeah.
that need to be on you. And I like how you said that we can filter essential personnel only. We don't have to be taking care of the erroneous things that can happen later or things that aren't pertinent to right now. If you had a pretty severe hemorrhage or you had a hysterectomy during birth, you're there for a couple days. You're not getting out of there tomorrow morning. They're not going to miss you. They will
Yeah.
be able to get back in touch with you before
And
you get discharged.
for sure. And I'll say another thing too, most of those people who are coming are in there 2 minutes and then they're out. So if
Totally.
and, like they all try to come right at the same time, like I feel like your first day you deliver, we do try to really stay out of there. But and then the next day in the morning is very busy. And that's when like the hearing screener, your pediatrician, your OB, WIC, birth certificate, they all try to just lump it and get it all done. So I don't feel like it's you being interrupted a lot. It's all just done very quickly. But
Mhm.
yeah, I definitely get that complaint too on my social media and I feel terrible and I'm like, "Oh, I wish everyone knew that they could." I don't want to say don't be rude, like for sure, but like you can advocate for yourself and just be like, I
Totally.
really need sleep. Like, is there any way you can please try to like cluster care really well and just for everyone to just leave me alone for a minute? And I will not be offended at all. If somebody asks me that, I'm like, I totally get it. So I've
Yeah,
been there.
I think once you've been there, done that, and you know what postpartum is like, you totally understand, and you're like, "I totally get it."
Yeah.
Okay, your pediatrician that comes by and sees your baby, what are they looking for? Are they doing any tests and procedures? And then are they gonna take all the information that they found about your baby and send it to your pediatrician? How does that work?
Yeah. Okay. So usually when they first come see your baby, and this depends on your hospital. So like at mine, we have a nursery. A lot of hospitals don't, and most of our pediatricians like the baby to come to the nursery for their assessment. But if someone's no, I want to be no separation, then we just tell the doctor, and they might not be happy about it, but they're supposed to go to the room and go see the baby. So
Totally.
or we have big glass windows by the nursery, so sometimes the parents will just walk down with them and they'll stand there and just watch the baby be assessed. And then when the pediatrician's done, give them back to the parents. So just letting you know, like some hospitals don't have nurseries though, and your ped does just come to your room. That's what they do. But just letting you know, you never have to be separated from your baby. The only time I could imagine that having to happen is if it is like a critical situation, like life or death, like baby needs to go be like if they need some kind of resuscitation and it's in an area that's I don't know. I don't even know why that would be the case. But for us personally, like our resuscitation area is in the back part of our
Uh,
nursery and people aren't allowed to come back there only because there's like other babies and like stuff so people can't come back there. So it's not like we're trying to not let you come back there. It's just we're not supposed to let anyone go in that back area because there's also sterile stuff back there. I don't know. So we just don't just want a bunch of people coming in, but there should be no reason you have to be separated from your baby unless it's an emergency or
mm,
something crazy.
yeah.
Okay, but sorry, I'm going off topic.
No, I
Um,
love it. Hey, I'm all for no separation unless the parents need a break, and then I totally support that as
yeah,
well. But I do know a lot of parents really do feel strongly about not being separated. So I really appreciate you giving people the confidence to say, you have the
yeah,
right to say, actually, could you do all of this in the room? We would just really prefer that.
yeah, for sure. Yeah, I have two doctors that I work with who will be like, nope.
What do
I
you
guess they
think their
just
holdup is? Why do you think they have such a strong preference for seeing them in the nursery?
one of the things they do say, which I think is valid, is like there's just better lighting in the nursery. We have some big overhead lights they can turn on so they can
Sure.
just so they can see the baby better. So I get that, but then also I think that they just want to be able to do their assessment without the parent just like, hovering
Interfering,
over
asking
them.
questions. Yeah.
Yeah, and they just and or they have a bunch of babies to see, and so
Mm.
like I don't have time to go to every room and then have lots of parents asking me questions. I'm like, that is your job, but whatever.
Kind of what you're paid for, but
Yeah,
okay.
I'm mean about it. But most of the time, everyone is really fine to come to your room and they're really nice about it and they don't care. They might be like, yeah, I don't want to, but they're going to do it. There's only two, and I work in a very big hospital. There's only two pediatricians who will just be like, nope, they're going to have to like walk down to the nursery. Sorry, I won't come down there.
Sure.
It is what it is.
In that case, could someone say, "We'll just wait for the next pediatrician"? Is there anything that's time sensitive?
I guess if they wanted to try to wait for, we have, honestly, I don't know what would happen in that case. I don't know because I guess like there like because there are specific groups that will come to the hospital to assess babies, and then we have like our kind of like our group. We call it like our hospitalist group of pediatricians who will see
Okay.
babies. Who, let's say that there's someone who lives like an hour away, and their pediatrician they have picked out doesn't come to our hospital. So we have this group of hospital pediatricians who will just assess the baby while they're there in the hospital. Does that make sense? I
Yeah,
guess.
yeah. Mhm.
Yeah, so they'll see them and then but then when they discharge, they will obviously go follow up and see their actual pediatrician. So like the issue is I don't know because it's one of those doctors is in that hospital group. So I really don't know who else they would see because they don't have a pediatrician who would come. So I don't really know. I don't know what would happen, but we'd figure it out. Maybe we could
Yeah.
ask another doctor. We'd figure it out. We're always going to advocate for our patients, so we'll figure it out. But
Okay,
yeah,
so what are we looking for in the assessments?
yeah, so they're doing like a head to toe on the baby. They check their pupils, they check their ears, they have their little otoscope and stuff, checking their for like tongue or lip ties, checking for cleft palate, just looking at their skin, checking their bottom, their genital area, like literally a head to toe, like very detailed, checking their back. And we do that too. The nursing staff does it and the pediatricians do it. And so they'll do that check and then that's pretty much all the doctors do. Like they'll do their check and then they usually go like after, like I said at my hospital, they'll check them in the nursery and then they'll go and talk to the parents and be like, I looked them over, this is blah blah blah, do you have any questions, whatever. So that's how that goes. And then we do draw our labs on the baby. So we do a PKU, which is the newborn screen. That gets done at 24 hours, typically like right around 24 hours. And that is the test. It's a state screening to look for kind of just like rare or unusual like genetic stuff like cystic fibrosis, stuff like that, like stuff that we would really want to know about if your baby does have it because sooner intervention could potentially be life-saving.
Sickle
So
cell
they do.
anemia is another one that they check for, and whether your baby is allergic to breast milk. There's a lot of things that we check for.
And we don't get
Each
the
state
results.
does it differently, I think, too, though. Each state has a different list of things they check for. Is that right?
I think so. I
Yeah.
think so. I think it does vary, but we don't get results back. It takes a few weeks, but it gets sent to
Oh.
yeah, it's a couple weeks, I think, but the pediatrician gets it. So when in the hospital, we fill it out. It's on this slip of paper. We also do part of it in the computer, but we have to prick baby's foot and we get these blood drops on it. Not many, it's 5 little spots where we put their blood and it gets tested and then the pediatrician office gets the results of it and then they'll let
Wow.
the parents know if there is anything. Usually you'd never hear anything about it. That's
Which is
normal.
good because
Yeah.
that means there's nothing found, right?
Yeah. Like
Yeah.
I like all three of my kids, like I got it done, never heard anything about it. They were fine.
Cool.
Yeah. You like probably won't hear anything. That's totally normal. Um, and then we also check their bilirubin levels and we might check other random blood stuff on them, but typically it's just their bilirubin is the kind of typical normal one we'll check. And we have to plot their bilirubin on a little chart and just make sure it's normal before they go. And then yeah, their hearing screen, if they need a car seat trial, the nursing staff will do that before they go. I'm trying to think. Car seat test, hearing test, the PKU, labs, and then as long as everything's fine on their assessment, then yeah, that's pretty much it, and then they're good to go.
Nice. Okay, talk to us a little bit about the bilirubin. Now, this is what causes jaundice. What is
Mhm.
the normal range that we're looking for? If your baby gets above that, what are we concerned with? And what is the kind of like key number that we're looking for to be able to be discharged?
Yeah, that's a great question, but it depends on the baby's age and
Okay.
hours. So the
Okay.
number, there's not like any one specific number, because when we plot it, it could be done at 2 hours of life, it could be done at 48 hours of life, and the number is going to vary based on their age. So the number usually does get higher and higher as they get older, but we want to plot it on this graph and make sure that it's not going outside of into the danger zone. So it's like a bell curve. I think that's what it's called. Don't quote me on that. I don't know. It's this
You did
graph.
your hand motion right for that's a bell curve. So basically
Okay.
it should come up and peak and then come down. Is that
Yeah,
right?
I think so. Yeah.
Okay.
Yeah. So I'm like, okay, I know it goes up, but then I think it like goes down. I don't know, because we're just doing it the first 2 days. So I'm like, I don't really know
Got
what
it.
happens after that. but you want to just make sure that it's staying within this, like we call it like the low risk zone. So it literally says on the chart, if it's like below a certain level, like it's fine. There's
Okay.
like low risk, low intermediate, which is like still usually fine. And then if it gets in the high risk zone, then that's when we like might need treatment with like lights, like Billy lights. And then there's like different levels they might do. So we can do like a Billy blanket, we can do Billy lights, we can do like over the bed. So we can do one, or we can do two, or we might do all three of them. So the blanket and
Wow.
two lights over the bed. That's like for very sick babies. But yeah, so that's like what we're checking where it is on the graph. And then the pediatricians have like a whole algorithm. We'll call them when we get the results back and be like, this is how old baby was in hours when we drew the lab. And this is what the number was. And then they'll check in their little algorithm that they use, and they'll be like, okay, this is like the treatment we need to do or not.
Got it. Okay. I know that can be very scary for people. Can be scary. Okay, hearing tests. What can we expect from that? Sometimes they're done in the room with you and sometimes they take your baby.
Mhm.
But what are we actually doing to our baby in that?
Yeah, so they don't, as far as I know, babies sleep through the whole thing. So it's
Okay.
not, I would not say it is invasive at all. They just put these little stickers on them. It depends. There's two different kinds in the United States that they do. The kind we do at my hospital is this one where they put these little like stickers on their head, and they just literally, it takes like less than 5 minutes,
Okay.
and it sends some kind of, I don't know because I don't do it, but it sends some kind of stimulus and it sees if they react to hearing it or something. I do not know. I do not know, but it
That's
is
okay.
very,
Is it done by an audiologist? Is that who does that?
it's somebody, they're like, I think they're like a tech. It's like someone
Got
who's
it.
just trained to do it.
Okay.
It's not a doctor, I know that. It's someone
Okay.
who's, they're a trained tech to do it. They can do it the first day of life on the baby, but I would say this is something that I'm glad you brought this up, because they might do it the first day on the baby and they may pass, but it's actually not uncommon for them to fail the first day, and that freaks a lot of parents out. And
Yeah.
that does not mean that your baby is deaf. Like, it just could be that they still have like fluid in their ears from, especially if they had a C-section, they're a lot more likely to have more fluid in their ears because they didn't get squeezed and coming
Hmm.
out like they do with a vaginal birth. So if they do the test the day of, a lot of times I'm like, yeah, they're probably not going to pass. So most of our techs, they just wait the second day or wait the
Sure.
day that they're supposed to go home. So they'll test them, and usually if they fail the first time, the next day they pass. Or if they fail a second time, they'll do it twice in the hospital. If they fail a second time, 9 times out of 10, even more than that, 99% of the time, they'll have them come back in 2 weeks. They'll actually make an outpatient appointment to come to the hospital, and they'll come and they'll do another check, and usually they pass and it's fine. If for some reason they still do not pass that time, which is very rare, but if they don't pass, then they would make an appointment with an audiologist, like a
Okay.
doctor for
Yeah,
that.
or an ENT or somebody like that.
Yeah.
Cool. Okay. Yeah.
Yeah.
Okay. Is there anything else that happens to our baby in postpartum that we should talk about? Now, the Hep B, the erythromycin, and the vitamin K should have already been administered at this point in L&D. Is that right?
It depends. Like in my
Okay.
hospital, they get the L&D nurse does do the erythromycin and the vitamin K.
Okay.
Sometimes if there is just, it's crazy stuff gets in the way, like sometimes it might be us, like in
Okay.
postpartum, we'll end up doing it. But always, usually we're the ones that do the Hep B.
Oh,
Or not me, usually my hospital has a charge nurse and then a transition nurse in the nursery. So usually one of them will do it. So it's not usually me doing it, but if I had to, I can. We'll do
Well,
that. But
and for anyone who's feeling a little hesitant about giving the vitamin K and the Hep B all at the same time, for people who are gonna delay it a little bit, but still get it
yeah, you
before you
can do that.
discharge, your postpartum nurse will do that as well.
Yeah. Yeah,
Um,
people do that all the time. They'll wait, or some people even just say for if they want to do the Hep B, they'll wait till their like ped appointment in a couple weeks too, and it's not a big deal. We're just like, okay, and they just have to sign a refusal form.
Got it. Okay, cool. What about feeding our baby? You mentioned that it was on everyone's mind. I agree. That's what I see as well. Like everyone's, I just want to get breastfeeding off to a good start. It's hit or miss whether your hospital has lactation support or not. Can you tell us
Mhm.
a little bit about what kind of training nurses have in lactation from nursing school, and then what kind of questions we should be asking our nurses in terms of helping us breastfeed? In my experience, most nurses are very well versed in breastfeeding, but I know that's not always the case.
Mhm. Yeah, like my hospital, we are very much, but I get stuff from people on social media all the time who's like,
That's where
no
I've
one.
learned it too. Yeah.
That makes me so sad. Or they're like, I ask for help and they're like, I don't do that. I'm like, okay, if you work in OB, anything, you should have at least a general knowledge, but whatever. But yeah, we do have lactation. We just have lactation on day shift, but like the hospital
Okay.
across the street from me, they have lactation day shift, night shift. Like, that's awesome. So, like, typically, you can breastfeed literally whenever you want. If your baby comes out, skin to skin, you can go and latch them right then. Usually, your L&D nurse will help you or be a little hands on to if that's okay with you, but just check and make sure you guys look like you're doing all right. And then I said we have a transition nurse, so they're the ones that go get the baby. They transition the baby, so make sure baby's doing okay, maybe help again with breastfeeding. And then the transition nurse will pass off report to us, the postpartum nurse. And then again, like we're there ready to help you with breastfeeding whenever. So usually when they come to me, like they usually nurse because we get patients 2 hours from after like birth, so they've usually already fed like once. So I usually help them like maybe their second or third time with latching. And for us personally, our training in nursing school, probably I got just not much at all.
Yeah.
Bare minimum knowledge. Definitely don't remember anything I learned from it. But for us personally, we have to do a ton of continuing education on it. So we have to do online training modules about it. We personally have to shadow a lactation consultant at my job for, I think it's one 12-hour shift, like when you first start working there. And then we have to do it once a year. So we just keep up with them. And then we even have to do, this is like something newer we just started doing in the last year, but we even had like classes that we had to go to. Like we did one on postpartum hemorrhage, we did one on lactation and like a few other topics, but it was like an in-person thing and had like a quick condensed just like master class on it. So we get educated on how to do like stuff with pumps. Like we have to be well versed in like how to set up the pump, how to use it when it's appropriate, when it's not. If someone is engorged, like what steps we're going to go through to help with that. Which that makes me really mad when someone is, I was engorged and they were like, I don't know how to help you or what to do. I'm like, we have a whole, this is what we're supposed to do and help you. We're not going to let you sit there because that can get turned into mastitis and that's a
Totally.
problem. But yeah, we get a lot of education on it and we are very, I feel like we usually only go to lactation if someone has, and we have usually at any given time on a shift, we have about 3 lactation consultants there, which is
Wow.
really good. But and they have to see everyone. They have to at least make sure everyone's been seen once a day by a lactation consultant. But I feel like we only try to grab them or use them if we run into an issue. Otherwise, most of the time it is us like helping latch and helping with feeding issues. So yeah.
Positions, different things like that.
Yep,
Yeah.
yep. We're trained in that and we're trained in hand expression, like showing you how to use a spoon or like syringe feed and like all that stuff. Yeah.
I love that. My wish is that every hospital cared about breastfeeding and prioritized breastfeeding like that. I know
Mhm.
that's just not the case. Okay, talk to us a little bit about baby weight loss, because that's always a thing that comes up. It's also expected. We expect your baby's going to lose a little
Yes.
weight. There is a normal range. So, what are we looking for in terms of that? And when would you say that it is appropriate to start supplementing, whether that be maybe with pumping your own milk, donor milk, formula feeding? We've already talked about all the options, but
Mhm.
I'd love to hear your advice on like when should we start having that conversation about maybe we do need to supplement a little bit?
Yeah, for us, our protocol is if the baby has lost more than 10% of their birth weight. So as long as if it even gets close to that though, then usually we're already having that conversation with the patient
Okay.
and the doctor, like what we need to do. So we usually suggest what you just said. We try to see if mom hasn't been pumping, we try to see if we can get her pumping, and if she's producing some more, we're topping off with that. But if it's like a serious kind of weight loss, then we might be like, we need to already start thinking about using donor milk because we need to like have more of an exact specific amount that we're giving or formula. If parents, we usually are like, these are your options. We have donor milk, give them the spiel about it. And then we have formula. So they have to sign a consent form if they want donor milk and all that. We go over all of the details about it. But yeah, we're also looking at pees and poops. I tell people we're also monitoring that. So we just also want to make sure baby is like having an adequate number of pees and poops for their how many days old they are, how many hours. So that's something to keep track of. It's not all just the weight, but usually if it's 10% or more, then we need to start supplementing.
Sure. And
Yeah.
does that change based on maybe someone's birth if they had a lot of fluid during labor or if they had a C-section during labor? Are we seeing trends where those babies maybe lose a little bit more because they had that artificial inflation of weight?
Yeah, and we're like we know that. We usually are like if I feel like a parent's really stressed about that, we know it's probably something like that. I'm like, don't beat yourself up because all that fluid that you got, that was in baby too, and that's super normal for us. We expect that. We know that's the case. But yeah, it is a conversation with the doctor too. Like we're keeping them in the like the pediatrician because they might not always know what happened with mom, but they usually know a broad overview for sure, but we'll tell them this is what's going on and where it's a conversation between everybody. So we're making
Mhm.
sure the pediatrician, the nurse, and the parent, they're all involved in what we're going to do.
Yeah, cool. I love that. Okay. Circumcision. If we're choosing to circumcise, what should we expect from that procedure?
Oh, this is always such a it's a rough topic. Anytime I talk about it, everyone like freaks out. I'm like, I'm
Well,
not
so the
going
thing
in.
is, I was about to say, the thing is, this podcast is not, we're not telling you to or not to. I just want to know what the procedure is. So if someone feels
Ah,
like it is right for them, they have the information on what's going to happen to their baby and what they can expect. So everyone who is getting your pitchforks, put them away. We're not trying to take sides here. We just want you to know
yeah.
what to expect, people.
I have my personal opinions about it, but I never tell anyone. I'm like, that
Sure.
is my, I'm like, it's my boys' decision when they want to share that with the world.
Sure.
But I'm not, because people are like, what did you do? And I'm like, I'm not going to tell you.
Doesn't matter what I did. What do you want to do with your baby?
Exactly. I know. And I love the article by Evidence Based Birth that she did on it because it's very unbiased. It's here's just the facts, here's the religious side of it, the social, the everything. You make the decision. I'm like, that's what I tell people to look at. But, anyways, as far as what gets done, so again, that is one of I told you there's only a couple times we might have to separate you from the baby. And one is if it's an emergency resuscitation type of thing or at my hospital, we do take the baby back to a sterile area to do it. But I do know there are some places that I think they do it in the room with the parent.
Wow.
Do you know that? What do they do at yours? Do you
Yeah,
know?
for the most part, at these big teaching hospitals, we're seeing them take the baby for circumcision. We actually have a fair amount of clients that decline circumcision either for religious purposes because it will happen a few days after, or just because they have chosen not to do that.
Yeah, for sure. It's not a big deal. I actually
Yeah.
feel like people declining, it is okay. Like no one cares. If anything, it's
Yeah.
like less work for us. Like
Yeah.
I'm like, I don't care. I'm like, okay, cool. But yeah, so as far as yeah, they'll take the baby away. We give them sweeties, which is like a little sweet water and a passy to calm them beforehand. We swaddle their arms just so they'll stay out of the way. So we'll put their little arms like just right here and then swaddle them so they're just out of the way. And then we have like our little sterile area where we do it and put them down. And then the nurse, we stay with them and help assist while the doctor
Okay.
does it. Not every hospital may do that, but we stay there with the doctor with the baby while they do it. It depends on the doctor, but typically like 15-20 minutes. And that's only because it depends on also the doctor and which type of circumcision method they use. There's 3 different kinds commonly used in the United States. There's the Mogan clamp, the Plastibell, and the Gomco. And some doctors will do like this cream that's like a numbing cream they have us put on beforehand. But most doctors do lidocaine. So they'll do the lidocaine injection and then they'll wait like some time for it to set in on the baby. And then the actual procedure, 15 to 20 minutes. And then the baby stays in the nursery. Usually they can go right back to mom if they want to, but usually they stay in the nursery because we do a check on their little pee every 15 minutes for 45 minutes.
Okay.
So we check it 3 times and then if the parent's like, I just want them back right away, totally cool. I'll just pop in their room every 15 minutes and just check it. So
You're
they don't
checking for bleeding, is that what you're checking for? Yeah.
yeah, which I was gonna get into that. So then whenever I bring baby back to the parent, I just say, okay, this is what we want to watch for. There's gonna probably be some amount of bleeding in the diaper, like a little bit, and that's okay. But if it is like filling up, if it is like saturating the diaper, if it is like a continuous, like it's not stopping, or it just does not look right to you, something is very swollen, anything, just please let us know, even if you go home and this happens.
Mm.
For care for it, I tell them you just take a square piece of gauze, and we give this all to you, but it's a square piece of gauze, the big old dollop of petroleum jelly on top, then you put it right on top of their penis and then you close their diaper. You don't need to wipe it or anything with a wipe. We try to just leave it alone. Obviously if there's like poop or anything, you can wipe that off, but we try to not really mess with the area. And then usually like it gets crusted over after a few days, and then you don't need to do the gauze and petroleum jelly anymore once it's crusty. You just change diaper, whatever, like normal. And then usually, I don't know, I can't say exactly how long it takes to be completely healed, but usually after a few days, it's like things are looking pretty normal-ish. And then one thing that's important, I feel like to mention, is feeding. Your baby might be pretty fussy or just grumpy or not feed well for about a day or so after. So they're just like, they don't feel good. So a lot of people will be like, I have a hard time getting them to latch, or like they're just you can just tell they just don't feel good. So that's pretty common.
Yeah. Cool.
Yeah.
Is there any questions that I haven't asked about kind of baby stuff in the postpartum that we should talk about that parents need to know?
Girl, I'm like, you asked me so much. I'm like, so you did so awesome.
Thank you very
Um,
much.
oh no, I was like, those are all great questions. They're amazing. Honestly, no, I feel like if there was one thing I could tell people, it'd just be to like just know that most of us are really want you to like we want to have a good, respectful relationship with you. Don't be afraid to say what you want, say what you need, speak up for yourself, decline things you want to decline, ask for whatever you need. And no one is going to judge you, because at least at my hospital, we are so like, yeah, whatever you want. We're here to just help you. I'm not going to say that we're not going to be a pushover, but we're also going to respect you. And it is your birth. I want people to not feel like, I know you see stuff about nurses being like crotchety and like being like, you're going to do what I tell you. And I don't work with anyone like that. We're all so sweet. And everyone there is just great that I work with. I love everyone I work with. They're amazing. I'm like, I feel bad. I know that there are bad nurses out there. I know that they exist. I have worked with bad nurses before. But for the most part, we're really great. And we just care about you and want you to be happy. And if you have a nurse who is just awful and just you guys are
Crotchety.
not right, crotchety, and you guys are not on the same page. Just know that you can always ask for a new nurse and ask for an assignment shift or change. It's not a big deal. It happens. It's totally fine. I wouldn't say do it willy nilly. Yeah, I just don't really, they're not my favorite person. Just don't do it for no reason. But if they really are like, I just do not want this person, then absolutely feel like you can ask for someone else.
Yeah, if you find yourself dreading your nurse coming in, or you find that you don't feel safe in the care, for me, those are 2 really big red flags that you should ask for a new nurse. And I always love to tell people, if you're feeling this way, chances are your nurse is feeling that way too. And they would be more than happy to hand you off to somebody that is a better fit for you. I agree, Kara. I think 99% of L&D and postpartum nurses are just angels on earth. But every now and then we do get somebody, and look, maybe they're just having a bad day and they're not necessarily a bad nurse, or maybe they just had a really rough shift and you happen to get them at the end of it and they are just like so done with that day and they're trying to hold it together and they just can't. We're all human at the end of the day. But yeah, thanks for reminding us that we can always ask for a new nurse because I think that's something that feels really heavy. You're like, oh, I don't want to upset them or be that patient or be like too
Yeah.
much, but I promise you,
Oh
we want you
no.
to feel safe and we want you to feel comfortable with the care that you're getting.
Yeah, and
Sure.
we're not gonna talk bad about you, like, "Oh, that girl, like, didn't want," like, I'm just like, "Oh my gosh," like, usually, if someone doesn't want someone, it's like, "Yeah, I can see that." Like, yeah, I'm like, there was probably I could just be like, "Yeah, I could see how y'all wouldn't probably weren't the best fit for each other," and that's fine, but, like, we're
Totally.
not, like, "Oh," like, judging you. No, like, no one's doing that, I don't know. So, it's fine.
I think that a lot of stories get really blown out of proportion on online and on social media, and sometimes people are portrayed as bad providers when in fact they were just not aligned. So to wrap up our conversation, I want to talk about one of the most taboo things ever and something that everyone's so scared about, and it's that postpartum poop. It's like
Oh,
so
yeah.
scary. Everyone's terrified of it. Sometimes we have people who hire us in their first trimester and they're like, I am terrified of the postpartum poop. And I'm like, you are
Aw.
6 weeks pregnant. Like, why is that on your mind already?
Oh
So,
my goodness.
talk to us a little bit about why our hospital staff might ask us to have a bowel movement. What are we checking for? Why do we need to do that before discharge? And then, if you have any tips to make that easier.
My hospital does not require you to have a bowel movement before you can go. Does yours?
Wow. Yes, we see that kind of commonly. It's not
Wow.
necessarily a requirement because you obviously can't require someone to do that, but it is highly encouraged. Let's get you to the bathroom. Okay, let's get some stool softeners in you. Okay, we're really
Mhm.
wanting you to take a bowel movement. So if you have to poop today, let me know. Things like that. It's really highly encouraged.
Yeah, I get that. I did not poop after my first baby for 10 days.
Oh,
So
wow.
I
Imagine
was
if they
dying.
kept you in the hospital
Yeah,
that whole time.
I was dying. I literally was Googling if I was gonna die. I was like, I was so
Oh,
scared.
no.
Yeah, it was not a fun time. And then even with my second, it was still like 4 or 5 days. And yeah. So, anyways,
Wow.
but as far as what we do, I'm like very pushy with hydration. That's gonna be
Sure.
huge. We do give stool softeners at my hospital too. Just it's like just standard protocol to offer them. You definitely don't have to take them. But then I even tell people if you go home and you just still cannot poop and you are very uncomfortable, please just don't hesitate to call your doctor and even ask like need a suppository or whatever. But I usually the things I tell people because when people ask me on social media, I am usually like try a Senecot tea, like a
Okay.
smooth move tea. I think that those are like one of the best things you can do, like a smooth move tea.
Wow.
Obviously, drinking the water, getting some movement and eating stuff that's high in fiber. And it's just honestly, it's just hard because if you're swollen down there, your body just is tight and you just don't really have that ability or your body's having a hard time relaxing.
Yeah.
Or if you've been dehydrated from losing all the fluids that you lose in labor. So things are more hard and it's harder for stuff to just come out. Dehydrated, so yeah, it's just don't stress about it. I will say when it's ready to happen, it's time, it'll happen. But you can make it easier by taking some stuff like that, the Senecot tea, or taking magnesium, or just stuff like that that's gonna help. And don't hesitate to call your doctor if you need like the big guns. If you need a suppository, if you need mag citrate or something like that, they can always call it in your pharmacy and you can pick it up.
Yeah.
So
Is Maxitrate magnesium? Because what comes to my mind is Calm Powder magnesium
yeah,
supplement. I always tell people to check with their providers depending on what kind
yeah,
of medications you've had in labor or postpartum, because magnesium can kind
yeah.
of interact with some of those things. But magnesium is a wonderful way to get your bowels going as well. Is that what you just mentioned? And also, is there anything right off the top of your head where you're like, okay, if you've had this or this type of medicine, definitely stay away from magnesium?
As far as like medication interaction, I'm not sure. I'm like, just always check with your doctor because
Always.
I don't
Yeah.
know. I would just double check with them. But I personally did use the calm, like magnesium.
Oh, yeah.
But the mag citrate that I'm talking about, that's like something you have to get from a pharmacy. And it comes in a little bottle, it's about that big, and it's a drink. So you have to
Okay.
drink it. And I don't know, I haven't had anyone tell me it tastes bad or anything, but it's just like it's mag citrate in a bottle, and it's like something the pharmacy has to make. But usually that one's a pretty strong one. Like usually that gets people to go. I feel like that or a suppository or a couple suppositories like does the trick.
Sure.
So
Yeah.
yeah.
All right. Cool. Oh my gosh, this has been such a good conversation. Did you mention earlier in the episode that you've written a book?
Yeah, I
All
did.
right. Tell us
It's
about that.
Sure, it's short, it's not long. I just wanted like a quick little down and dirty guidebook, but you can get it on Amazon. You can get it as an ebook, just download it to the Kindle or Kindle app, and it's $3 or $4, I think, if you do it like that. And then the paperback, if you want it, you can get it from Amazon too. So it's like the option for paperback or for an e-download. But yeah, it's called Why Didn't I Learn All This Parent Stuff Sooner? And I wrote it on when I was just on maternity leave with my third baby. And so I was like, I'm just gonna write this real quick. But I had been wanting to do it for a long time and had all of the thoughts to do it. So it's just 20, I think it's 20 chapters, and it just is a lot of it is stuff we talked about now, but also a lot of other things like I talk about, like questions to ask your OB before you hire them, how to interview your pediatrician and pick the right pediatrician for you, how to get your house ready beforehand, like things I would put around your home and have prepared before baby gets here and stuff like that. So, yeah. And then I also have a baby sleep course that I wrote. It's a video course, and it's Why Didn't I Learn All This Sleep Stuff Sooner? And so I have that too. And it's, if you like go to my website, my link in bio, I think it's the top one there.
Cool. I
Yeah.
love that. Okay. You've briefly mentioned your social media stuff, but where can people find you if they want to learn from you from your book or your sleep course, or if they just wanted to follow along because they
Yeah.
have fallen in love with you like I have?
Oh, that's so sweet. But yep, they can find me on all the platforms. I'm on TikTok, YouTube, Facebook, Instagram. I think that's it, all four. It just Kara the baby nurse. Kara with a K.
Hey,
K.
yep. Kara. All right, you
Yeah.
guys. Thank you so much for hanging out with us today. Kara, thank you so much for coming on, spending time with us, sharing your wisdom, and really giving us the confidence to know what to expect or once we leave labor and delivery or once we transition in the same room to postpartum care. I really appreciate just you being here and spending time with us. All right, listeners, I will see you next time on our next episode. In the meantime, connect with Kara on all social medias, and I'm at Tranquility by HeHe on all platforms. Bye.
Bye.
Thank you so much for tuning in today. I truly do value this community and I love hanging out with you. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent. It's an honor to be your go-to gal when it comes to preparing for your baby. If you found today's episode helpful, share it with a friend. Share it with someone who could use evidence-based information to help them have an informed and confident birth. I'd love to hear what you have to say and read your sweet words. By leaving us a review, you are helping other expectant mamas and their families find the podcast so that we can reduce birth trauma and improve maternity care in the U.S. one birth at a time. If you're interested in joining the Birth Lounge, go to thebirthlounge.com. If you want to connect with me on socials, you can find me at Tranquility by HeHe on all platforms. Until next time, stay educated, stay supported, stay confident. Bye.